All right, welcome back. Today we're diving into something that every single surgeon grapples with, surgical site infections, or SSIs. Now, these can be a massive headache, but here's the good news. This is a fight we can absolutely win. So let's get right into it.
So let me kick things off with a question for you. When you think about all the different infections a person can get in a hospital, which one do you think is the most common and the most expensive anywhere in the world?
Yep, you got it. Surgical site infections. They are a huge deal. But the single most important thing to remember, and this is really the whole point of our talk today, is that most of them are preventable. And that prevention all starts with a very specific way of thinking.
We're seeing this big shift in surgery towards what's being called the safe surgeon paradigm. And look, this isn't just some fancy new buzzword. It's a real, fundamental change in focus. It's about having proven skills, rock-solid clinical judgment, and making patient safety the absolute #1 priority in every single thing you do.
So what does it mean to be a safe surgeon? Well, it means you can see trouble coming from a mile away. It means you trust the data and follow protocols that we know work. And it means you really get the timeline of how the body heals. This is our roadmap. So come on, let's think like safe surgeons together.
You know, the easiest way to deal with an infection is to make sure it never gets a foothold in the first place. A safe surgeon sees the operating room as the place where you build this invisible protective bubble around the patient. Every single step we're about to talk about is just another layer reinforcing that bubble.
Okay, these are the basics, the absolute core four, and they're so powerful. First up, skin prep. The undisputed champ here is chlorhexidine alcohol. Next, you've got to keep your patient warm. A core temperature of 36 degrees Celsius or higher is non-negotiable. It helps the immune system work properly. Third, oxygen. We're thinking about higher concentrations, especially in big cases like colorectal surgery. And last, but definitely not least, the fundamentals. Strict, obsessive sterility, and keeping people from wandering in and out of the OR.
Now let's zoom in on the highest risk area, colorectal surgery. Here the evidence is just overwhelming. The combination of mechanical bowel prep plus oral antibiotics, we call it MBP plus OAB, is the gold standard. It crushes infection rates. But that's only part of the story. There's another simple, brilliant move that happens right at the very end of the case.
All right, picture this. You're in the OR. You've just finished the tricky part of a right hemicolectomy. The bowel is reconnected. Now, before you even think about closing the patient's abdomen, what is the single most important evidence-based thing you do next?
Just take a second to think. You've just handled contaminated bowel. How do you make sure none of that contamination gets into the clean layers of the abdominal wall as you close?
The answer, of course, is C. It's so simple, it's brilliant. The entire team gets fresh gloves and you bring out a completely new, totally sterile tray of instruments just for the closure. This is what we call the clean closure technique, and it is a game changer. This one simple habit has been proven to dramatically lower infection rates. It's an absolute must-do. All right, our next layer of protection is the pharmacological shield. You know, giving antibiotics before surgery isn't just about checking a box, it's about precision. The big idea here is that timing is absolutely everything, and believe it or not, less is often more. Okay, there are 3 rules here, and you've got to know them cold. Rule number 1, timing. The antibiotic has to be in the tissue before you make the cut, so you start it within that 60-minute window. Rule 2, redosing. Antibiotics don't last forever. You have to give another dose for long cases, like every 4 hours for cefazolin, and you have to redose after major blood loss. Rule 3, stopping. This one is huge. Prophylaxis stops within 24 hours, period. I don't care if there are drains, I don't care if there's mesh, 24 hours and you're done. Let's put those rules to the test. You're in a long, tough case, an 8-hour esophagectomy with a lot of bleeding. You gave the first dose of cefazolin right on time. To keep that protective shield up, what do you do next?
Okay, think back to what we just said. Remember, there are 2 different reasons you might need to redose. Did this case hit one of them, or both?
And the answer is C. You have to account for both factors. You redose at the 4-hour mark because of the drug's half-life. That's a given. And you give another dose after that big blood loss because all the fluid resuscitation has diluted the antibiotic in the patient's bloodstream. A safe surgeon is always thinking ahead and correcting for both time and blood loss.
Okay, but let's be real. Even when you do everything perfectly, sometimes things still go wrong. And this is where the safe surgeon's mindset has to pivot. We go from proactive defense to being reactive and decisive. It's all about spotting trouble early and acting fast.
A perfect example of this is when surgical mesh gets infected. It's a tale of two different types of mesh. Think of macroporous mesh as a chain link fence. The holes are big enough for your body's immune cells to get in there and fight. You can often save it. But microporous mesh, that's like a solid brick wall. Bacteria get behind it, form this slimy, impenetrable biofilm, and just hide. The infection will never go away until you take out the entire wall. That mesh has to come out.
Now let's talk about infections inside the abdomen. There was a huge study called the Stop It trial, and it completely changed how we do things. It proved that once you have source control, meaning you fix the leak or drain the abscess, you only need 4 days of antibiotics. That's it. A short, fixed course. More is not better.
Okay, here it is. Our last and most important scenario. It's 5 days after a colon resection. Your patient is sick. I mean, they have a rock-hard belly, their lactate level is climbing, but you get a CT scan, and the official report says, no leak. So what's the move? What does a safe surgeon do now?
This is one of those moments that truly separates the good from the great. The pieces of the puzzle don't seem to fit. So what do you trust? The sick patient right in front of your eyes, or the piece of paper with the scan report?
Before I give you the answer, I want you to burn this phrase into your brain. It might be the single most important rule in all of surgery. Physiology trumps imaging. The way your patient looks and feels is the ultimate truth.
The only right answer here is C. You are going back to the operating room, and you're going now. A CT scan can be wrong, but a sick patient with peritonitis after colon surgery has a leak until you prove otherwise with your own 2 eyes. You always treat the patient, not the scan.
Whew, okay. We've gone through a ton of material, from building that protective bubble to handling a full-blown crisis. So let's boil it all down into a simple, practical checklist you can actually use. Here's your game plan. Know your risk right from the start. Always use those preventative bundles. For colorectal cases, master the MBP plus OAB combo and that clean closure technique. Live by the 3 antibiotic rules, especially that hard 24-hour stop. For infections inside, it's source control first, then the 4-day antibiotic rule. Triage leaks logically. Grade A is minor, you watch. Grade B is a contained abscess, it gets a drain. Grade C means peritonitis, and you go to the OR. And above all, never, ever forget, physiology trumps imaging.
Look, knowing this stuff is one thing. Actually doing it every single time is what saves lives. So my question for you is this. What is one habit, just one thing from this list, that you're going to consciously start doing today? Think about it. Thanks for digging in with me.